So the topic this morning that I was asked to talk about is the role of chemotherapy for isolated locorregional recurrence, and the question was posed, is it worth? What I'd like to do briefly this morning is to talk a little bit about the clinical significance of isolated locorregional recurrence. I will talk a little bit about the effect of systemic therapy on rates of locorregional recurrence, which is a little bit of an aside, but is actually an important component, since the rates of locorregional recurrence have significantly decreased over the past several years, mainly through the effective use of systemic therapy. And then I will talk about the effect of what we call adjuvant, quote-unquote, chemotherapy at the time of locorregional recurrence. In other words, reintroducing adjuvant chemotherapy to these patients. Now, I'll go back to the nsabp B06 trial, which was the trial that actually first, at least in a big way, brought into the forefront the issue of locorregional recurrence and eventually its significance. As you remember, this was a trial that compared total mastectomy with axillary dissection to lumpectomy with axillary dissection, or to lumpectomy with axillary dissection plus breast radiotherapy. And the last update that was published in 2002 by Bernie Fisher, 20 years later, obviously showed that there were no significant differences in outcomes. However, as you remember, this study showed significant differences in the rates of locorregional recurrence, particularly in breast recurrence. And when you look actually at all patients, we see that 20 years later, lumpectomy alone patients where no radiation was given had a 39% rate of recurrence in the breast, called now IBTR, or ipsilateral breast tumor recurrence. But patients that had lumpectomy and radiation were reduced to 14%. And clearly, this study showed a significant effect of radiotherapy in the breast in reducing ipsilateral breast tumor recurrence. Now, an interesting observation from this trial was that patients that were non-negative at the time of presentation had a 36% risk of ipsilateral breast tumor recurrence with lumpectomy alone, and 17%, almost about half, with lumpectomy plus radiotherapy. However, patients that were not positive when presented into the trial had a 44% risk of in-breast recurrence with lumpectomy alone, which obviously was higher because they were not positive. But interestingly, when they received radiotherapy, the rate dropped to 9%. Now, what was different about these not positive patients? Well, what was different was that these patients at the time were also treated with adjuvant chemotherapy, although not negative patients were not. Adjuvant therapy at the time, adjuvant chemotherapy was not routinely used yet, so we started to use it in not positive patients. So this was the first demonstration that there is a potential synergy between radiotherapy and systemic chemotherapy in reducing rates of local recurrence. Now, subsequently, we've seen this time and again, and this is just a data set from the nsabp, but there are several other data sets that have documented that the addition of systemic therapy will significantly reduce the rates of local recurrence. This is a compilation of nsabp trials, non-negative trials, looking at the effect of chemotherapy for ER-negative disease in the B13 trial, or looking at the effect of more effective chemotherapy, if you like, with CMF versus a two-drug combination of methotrexate and 5-FU, or the effect of tamoxifen for ER-positive patients, or even the effect of tamoxifen plus chemotherapy versus tamoxifen alone. And this is the incidence of ipsilateral breast tumor recurrence in all these non-negative trials. And if you look across here, it's very clear that the addition of systemic therapy or more effective systemic therapy significantly reduces the rate of ipsilateral breast tumor recurrence. These were all patients that received lumpectomy and radiotherapy. So it's a very consistent theme that the addition of chemotherapy, effective chemotherapy, or hormonotherapy will reduce rates of ipsilateral breast tumor recurrence. Now, the B06 trial was published and eventually in 1991, Bernie Fisher wrote an editorial, and I was part of that discussion and the design of this paper, looking at the significance of ipsilateral breast tumor recurrence. How could it be that we had such a big difference in local recurrence in the breast in the BO6 trial, and yet there were no significant differences in overall survival? So what we found in that paper was that the ipsilateral breast tumor recurrence was a powerful independent predictor of distant recurrence. In fact, the risk of distant recurrence was about 3.4 times greater in patients that had IBTR versus those that did not, after you adjusted by all the covariates. And while mastectomy or breast radiation following lumpectomy prevented or reduced the occurrence of ipsilateral breast tumor recurrence, they did not reduce the risk of distant disease. So if you take these two statements together, then you have to conclude that ipsilateral breast tumor recurrence was a marker for risk for distant recurrence, but not necessarily a cause of distant metastasis. So those patients were deemed to do poorly, and it so happened that they also got an ipsilateral breast tumor recurrence. Now, subsequent to that, many publications have come out that have shown that locorregional recurrence is a significant predictor of distant recurrence, and all types of locorregional recurrence have been associated with increased risk of subsequent distant recurrence, either an ipsilateral breast tumor recurrence after lumpectomy, or chest wall recurrence after mastectomy, or even more so, regional nodal recurrence after any type of breast procedure. Now, the magnitude of risk of subsequent recurrence, distant recurrence, varies depending on the type of local recurrence. And in fact, as you will see in some of the data I will show you in a minute, as you go down, lumpectomy, ipsilateral breast tumor recurrence after lumpectomy has less risk for distant recurrence that has chest wall recurrence after mastectomy or regional nodal recurrence after any type of procedure. So we published the compilation of the nsabp trials looking at ipsilateral breast tumor recurrence on a couple occasions. This is the compilation of our node-positive trials, looking at the outcome of patients after ipsilateral breast tumor recurrence, this is the lumpectomy patients, or any other type of locorregional recurrence, including the mastectomy patients. So if you see here, 5 years after local recurrence in the breast, the 5-year distant disease-free survival was 51%. So about 49% of these patients presented with node-positive disease and having an ipsilateral breast tumor recurrence ended up having a distant event. And when it came to survival, 40% of those patients were dead 5 years later. So not a very good prognosis after ipsilateral breast tumor recurrence. And if you suffered other locorregional recurrence, things were even worse. The 5-year distant disease-free survival after other locorregional recurrence was 19%, and survival was 24% 5 years later. So this is for node-positive patients, and this was published in JCO in 2006. Another paper compiled the node-negative trials, and again, in the same mode. This one is here also with the confidence intervals around the estimates, but shows essentially the same thing, that if you have an ipsilateral breast tumor recurrence after node-negative breast cancer, the 5-year distant disease-free survival was 67%, so 33% chance of distant metastasis, and the overall survival 77%, so 23% chance of dying from breast cancer. And if you suffered other locorregional recurrence, the 5-year distant disease-free survival dropped to 28%, and eventually the survival was 35% 5 years later. So clearly, suffering a locorregional recurrence is not a very good event, as you can tell. So actually in 2001, about 10 years after the publication of the Lancet paper by the nsabp, I was asked to write an editorial for JCO on the significance of ipsilateral recurrence, and I labeled that is it time to take the bull by the horns, because obviously there was a big bull, locorregional recurrence, and we weren't doing much about it other than documenting its poor outcome. So I quoted the Lancet report showing that an IBTR has importance beyond the need of its removal, since it is a marker for the propensity of a primary tumor to give rise to distant metastatic disease. Additional systemic therapy should be considered when an IBTR is diagnosed. Now, despite these findings, there continues to be widespread variability in the use of systemic therapy at the time of IBTR. This was back in 2001. And over the past decade, since the Lancet paper came out, there have been no randomized clinical trials evaluating the worth of administering another round of adjuvant therapy or adjuvant chemotherapy at the time of ipsilateral breast tumor recurrence. Now, there was a practical issue at the time, and that was we didn't have new drugs at the time. So if somebody already had gotten CMF or an anthracycline-based regimen when they were diagnosed, what was there to give at the time of recurrence? But with the development of taxanes, gave us another opportunity to test these concepts, because now we had non-cross-resistant chemotherapies that could be put to the test at the time of local recurrence. So independently, in 2002, the International Breast Cancer Study Group, and BIG in Europe, initiated a trial to evaluate the worth of chemotherapy in patients with IBTR or other local-regional recurrence. And independently, the nsabp had developed a protocol, nsabp B37, to actually test the same concept. After several years, we were able to develop this protocol. Now, there have been attempts for adjuvant chemotherapy before in a Swiss trial, which actually failed to accrue and was discontinued. So we did not have any information. So ultimately, the two groups got together, the nsabp and IBCSG and BIG, and developed a common trial, which essentially, the two trials were very similar, called the Callow trial. And this is a trial that aimed to evaluate the role of adjuvant chemotherapy for patients suffering local-regional recurrence. So patients had surgery at the time of local-regional recurrence to remove local-regional recurrence. They could have also received radiotherapy at the discretion of the investigator, and then they were randomized to chemotherapy or no chemotherapy. If they were ER positive, they were allowed to get endocrine therapy, and if they were HER2 positive, also HER2-directed therapy was optional. The primary endpoint of the trial was disease-free survival, with secondary endpoint overall survival, and then all the analyses were supposed to be according to the intent to treat. Chemotherapy was left at the discretion of the investigator. The recommendation was for at least 2 drug regimens and at least 3 to 6 months of therapy, but we did not legislate the type of chemotherapy that was to be given. Now, we had trouble accruing to this trial. This was a difficult trial to do. The original sample size called for the hazard ratio of 0.74, so wanted to detect a 26% reduction in disease-free survival events. So we would have required 977 patients and 347 disease-free survival events. However, due to low accrual rate and the fact that we now had more effective chemotherapies, we revised the statistical plan in 2008 to actually look for a hazard ratio of 0.6, meaning a 40% reduction in disease-free survival event, and that dropped the sample size to 265 patients and 124 events. Assuming that the 5-year DFS for the observation group would be 50%, that would give us enough power. However, even that proved to be a daunting task, and we ended up re-amending the trial to close the trial eventually in January of 2010 with 162 patients and no plans for interim analysis, but the analysis plan was to conduct the analysis when the median follow-up reaches to 4 years with a minimum follow-up of 2.5 years. And eventually, the data were presented in San Antonio in 2012 and eventually published at the Lancet Oncology, as you see here. So this is a trial profile, 162 patients randomly assigned to chemotherapy versus no chemotherapy. 5 patients in the chemotherapy arm did not receive chemotherapy, they declined, and 1 patient in the no chemotherapy arm ended up receiving chemotherapy, but the analysis, as you can see, was according to intent to treat. So we analyzed all 85 patients in this group and 77 patients in this group. When you look at the baseline characteristics, you can see that about the primary surgery for the tumors was mastectomy at about 40% and lumpectomy in 60%. Prior chemotherapy was equally balanced, 58 and 68% between the groups. The median time from surgery to its isolated locoregional recurrence was about 5 years for chemotherapy group and 6 years for chemotherapy group. And menopausal status, the majority of these patients were postmenopausal, about 2/3 to about 80%, or 3/4 to 80%. And the median age at isolated locoregional recurrence was 56 for both groups. When you look at the location of the isolated locoregional recurrence, about half were in the breast, about a third were in the chest wall, and about 13% were in regional nodes, and they were equally balanced in the two groups. Estrogen receptor status positive in about 2/3, and progesterone receptor status positive about a half of the patients. If you look at the chemotherapy that was received, it was monochemotherapy in about 29%, either docetaxel or paclitaxel 19%, capecitabine 11%, and polychemotherapy in 65%, including CMF, gemcitabine plus navalbine, anthracycline-based in 45%, taxane-based in 15%, and anthracycline and taxane-based in 1% of the patients. So it gives you a flavor of what kind of chemotherapy was used. Now, these are the results of the trial, and surprisingly, given that we had hard time to accrue, we're able to actually get positive results. As you can see, the 5-year disease-free survival and overall survival were significantly improved with the addition of chemotherapy to these patients. As you can see, DFS difference about 12%, and overall survival difference also about 12% better with chemotherapy. When you look at the multivariate analysis for disease-free survival, we see that treatment, chemotherapy versus no chemotherapy, was a statistically significant and independent predictor with a hazard ratio of 0.49, meaning that chemotherapy reduced the odds of recurrence by about 50%, more so than we expected. That's why we had a positive trial, even with less number of patients. Now, when we looked at the patients according to the estrogen receptor status, we see here that for estrogen receptor positive patients, there did not seem to be a difference, but for estrogen receptor negative patients, there was a huge difference in disease-free survival. When you looked at overall survival, we couldn't make the same observations. There was potentially some benefit in either of the two, although none of this is statistically significant because of the low number of patients. When we tested the interaction between estrogen receptor status and treatment, we see that there was univariate interaction that was statistically significant when it comes to disease-free survival, but not for overall survival. So the interpretation of this data is that adjuvant chemotherapy should be recommended for patients with completely resected, isolated locoregional recurrence of breast cancer, especially if the recurrence is estrogen receptor negative. Furthermore, we commented that the beneficial effect of chemotherapy in patients with estrogen receptor positive isolated locoregional recurrence cannot be excluded because the confidence intervals were wide and the 4.9-year median follow-up might be too short to detect a treatment effect. Thus, any benefit of chemotherapy added to endocrine therapy remains uncertain in the ER-positive cohort, and this uncertainty also applies to the choice of initial adjuvant therapy for some patients with estrogen receptor positive disease, particularly since these patients get significant benefit from change in endocrine therapy at that point. So in summary, the Callow trial is the first randomized study supporting the use of chemotherapy in patients with isolated locoregional recurrence, especially if the recurrence is estrogen receptor negative, although again, it does not exclude use of chemotherapy for patients with estrogen receptor positive isolated locoregional recurrence. I would like to conclude by reminding you that the next SIS World Congress of Breast Healthcare is October in Orlando, my hometown now, and I'd like to remind you we have a tour planned for the attendees if you wish to attend of our UF Health Cancer Center. So looking forward to seeing some of you in the tour in October. Thank you very much for your attention.